Our next speaker is Dr. Emily Wang. Dr. Wang completed her training in internal medicine at the University of California, San Francisco. Her clinical and research interests are how to engage former prisoners in the healthcare system upon release, and how physicians can create systems of care that better support this vulnerable population. Dr. Wang has worked in prison systems throughout California, North Carolina, and Botswana. She has helped co-found Transitions Clinic, which is a post-release clinic for parolees with chronic mental conditions based in the Southeast Health Center in Bayview. In addition to providing primary health care, the clinic links former prisoners to community resources, including mental health services, substance abuse, and case management programs. Now, the question for Dr. Wang is, what medical issues do you commonly find among the reentering population, and what are the challenges in providing this care?
So I thought I would just answer this question and taking it back to one of the patients that Dr. Hong and I have seen in Transitions Clinic. And I met Mr. Smith sometime this spring in April. He was recently released from San Quentin. We'd met him first at the PACT meeting that Lorna and all parolees had attended. And he'd been incarcerated for 10 years in San Quentin. And it was there that he'd been diagnosed with diabetes, hepatitis C, and depression. Mr. Smith, he's representative of many of the parolees that we've seen in clinic. In this population, there's a high prevalence of communicable diseases, HIV, hepatitis C, tuberculosis. There's also a high prevalence of untreated mental illness. And frequently in this population, there's later stages of chronic diseases. So in the Bureau of Justice Statistics that was published in around 2000, nearly 1/3 of all state prisoners, they report having a physical impairment or mental condition. 2/3 report having a substance abuse problem, and approximately 18% or so report having a serious mental illness. In San Francisco, in a pilot study that Transitions Clinic is conducting, what we found is that approximately 40% of parolees that have been surveyed have a chronic disease upon release for which they are taking medications when they're in prison, so approximately 40%. So in spite of this high burden of disease, the transition from prison health care, where people are constitutionally guaranteed health care, to community care is often lacking and poor. Mr. Smith, in his case, he was given 2 weeks worth of medication. So what that amounted for him was a bottle of insulin, no syringes, no machine to measure his blood sugar, and then a 2-week supply of Prozac. No follow-up, and he had no clue where he was going to get his health care. And on average, what we've seen in our clinic is that folks have on the order of 3 weeks of medication or less upon release. There are very few plans for primary care upon release. And so parolees, when they're released, they're unable to get health care, and naturally they present to the emergency department for basic requests like refill of medication. They're also seen for non-urgent complaints, and then worse yet, serious illnesses because they were unable to get health care. In a recent study that was published in Washington State Parolees, and I was astounded by this, what it showed was that the risk of death 2 weeks after release from prison is 10 times higher compared to the same population of people the same age. So 10 times higher the 2 weeks after release. And it's for this reason that we've started Transitions Clinic. It's a post-release clinic at Southeast Health Center, and it's basically to bridge this gap for this very vulnerable, oftentimes unhealthy population. And one of the key features of this clinic is that folks don't have to wait for their 3-4 months primary care follow-up appointment. They will see us within 1 to 2 weeks, guaranteed, after release, after parole. So regarding the kind of challenges in taking care of this population, apart from their physical health, I would say that there's 2 primary challenges that we've noticed. The first one, I would say, is that there is just no systematic plan in place for medical discharge for patients with chronic medical conditions. So when you can imagine, when any of us have been discharged from the hospital in the community, you get a follow-up appointment with your primary care physician, and at the very least, medications sufficient to last you to that primary care appointment. And in my mind, I think that for this patient, he ought to have received the same, a primary care appointment in the community to which he's paroling, and medications that would last him to that point. Patients ought to be released with their medical records so that the physician that's going to see them knows what happened in prison when they were incarcerated for 10 years. Mr. Smith, in our patient, he's an insulin-dependent diabetic, and he was given a bottle of insulin upon release. And my question is, how is he going to get syringes without a prescription? And how is he going to get a prescription without a doctor? It's just impossible. So that's the first big challenge, I would say. The second is that while I think as a doctor that the provision of health care is critical in this population, that it's just not sufficient to ensuring the health of the folks in our community. And what we've heard today, and will continue to hear this afternoon, is that former prisoners returning to our communities face nearly insurmountable barriers to reintegrating. And this is on the level of policies that prohibit obtaining food stamps, welfare, public housing. One thing that bothers me particularly as a physician is that if you're incarcerated for over 12 months, that your Medicaid terminates instead of suspends. And so people that had insurance prior to having been incarcerated, upon release, they're without health insurance. And in my mind, I think that these barriers, they prevent former prisoners from accessing urgently needed health care after release. There are a lot of competing needs after release. People are looking, like what Lorna said, people are looking for food, they're looking for shelter, and they're looking for employment. And frequently their health care is a lower priority. And for folks like Mr. Smith, a person who has insulin-dependent diabetes, this can be a life or death issue. I guess our question is, who's responsible when he shows up to the emergency department in a diabetic coma? And this happens not infrequently. So in returning to Mr. Smith, when he came to our clinic, we refilled his medication. We gave him a machine to test his blood sugar. He was referred to Narcotics Anonymous, a GED program at City College, and also All of Us or None, a lot of these community providers sitting here at this table. But when he walked out of the clinic, I mean, he was still homeless, still without a job. And not 2 weeks after he saw me in clinic, I received a call from the San Francisco General Emergency Department from a fellow physician there. He'd been picked up by the police after having broken into a car because he didn't have money for food. And he was being seen in the emergency department for low blood sugar. And so what gets me about him is that in his case, he had insulin, he had a physician. In fact, he was using his insulin. He had a physician, and what he didn't have was food and shelter. And so part of the reason why I'm part of this council and why I'm really committed to our endeavors here is that until San Francisco enacts a comprehensive plan for reentry, like the one that the Safe Community Reentry Council is proposing, which includes the provision of basic fundamental human needs, food, shelter, health care, the needs of our parolees just can't be met. And we're going to continue to perpetuate this gross cycle of return to prison and return to poor health.
Thank you, Dr. Wang. That was great.